this case that I didn't initially see the patient back in January. It was Dr. Safras Beg who consulted on the case and as a registrar at the time. And then thanks to Dr. Papas for his photographs and his follow-up of the patient. But when I was preparing this this talk, my mind kept coming back to this this story that I've had to read many times to my son. And for those of you that have children that are under the age of 2, then this is a highly recommended gripping tale of false accusation, catastrophe, and ultimately reconciliation. But moving on to the case, sorry, we saw this. Well, they saw this 32-year-old HIV positive woman who had advanced HIV. She had a C4 count of 2. She was diagnosed with disseminated TB in November of 2020 on the basis of splenic microabscesses. At the same time, was also found to have had esophageal candida. And of note, she also had previous syphilis treated back in 2018, and her RPR, which was 32 at the time, was now 1 when she was presented in January. But she was started on to a efavirenz-based regimen in November of 2020, and then she presented in January with widespread nodular lesions for about 3 weeks with associated fever and weight loss. She actually was admitted around about the 7th or the 8th of January, and then her COVID swab, I think the initial one was negative, and then it subsequently was positive on the 12th, so may well represent a nosocomial infection. At the time, this is already the peak of the, or sort of just past the peak of the second surge. But of note, she had no real respiratory symptoms. And this is just to show that she had these multiple nodular lesions and essentially different sizes, but some of them looking a bit pedunculated, some crusting, sort of erythematous looking, and not really very painful, according to her. And of note, in terms of the rest of her, the notes are a little bit scanty from that time, understandably, but there's no real evidence of any systemic disease. She did have some lymphadenopathy noted, but not very impressive, and she didn't have anything on her abdominal examination, and also her blood workup also didn't suggest systemic illness. So at the time, the sort of considerations would have been as follows. You know, someone with advanced HIV presenting with these multiple skin lesions. And so the logical next thing to do would have been to do histology. And this is the report. And what the sort of key finding there was that there was this proliferation of capillary-sized blood vessels within the sample. But they did comment that, unfortunately, the clinching feature for what ultimately the diagnosis we've made was not possible. They said it should have been a Wharton starry stain, contaminant bacilli on that slide. But importantly, the HHV8 was negative, so making this very unlikely to be KS. So at this point, this is what we would have liked to have seen on a Wharton starry stain, would have been these bacilli. But at the time that the diagnosis of a probable Bacillary Angiomatosis unmasking iris was made, and at this point she was given doxycycline 100 milligrams twice daily. And the next 2 slides are just showing that after a month, more than a month of treatment, she's had some very noticeable improvement in both the size and appearance of these lesions. Some of them have disappeared completely. And likewise on the hands and the arms, we note that these lesions are improving really nicely. Just to say before I move on that, you know, Bacillary Angiomatosis iris is something that's described in case reports in the literature, typically in patients with very, very low CD4 counts, advanced HIV. Let's talk a bit more about the Bacillary Angiomatosis itself. It was first started to be described in the 1980s in these patients who presented with these lesions, with typical feature of this vascular proliferation within the lesion. And ultimately, the organism identified was Bartonella henselae and Bartonella quintana as the specifically involved organisms. And we're going to go into more detail about those as we go on. And importantly, they're difficult fastidious organisms, as we know, to grow, requiring prolonged bacterial culture. This is just showing on the left the different appearances, so different appearances of Bartonella quintana and henselae. The left showing these what look like more sort of similar size and deeply embedded in the agar, and on the right, heterogeneous appearing and not deeply embedded. I'm sure our microbiology colleagues can tell us more about the challenges. I've just put those slides in for interest. And just to take a step back, obviously Bartonella species causes quite a range of disease in humans, and there are, as you can see, there's the spectrum all the way from cat scratch disease with henselae, Bacillary Angiomatosis with henselae and quintana, and then there's a number of them that are implicated in bacterial endocarditis and culture-negative endocarditis, sometimes later finding out as one of these most fastidious organisms. And then just interestingly to mention as well, Bacillus, Bartonella bacilliformis, which is kind of endemic in South America, particularly in Peru. And there's the acute form where they present with this arroyo fever with hemolytic anemia and jaundice and hepatomegaly, and in the chronic sort of endemic form where they have these very impressive vascular proliferative lesions. In terms of the sort of bit more about henselae, the cats are the sort of primary reservoir of the disease, and the combination between cats and cat fleas in interaction with humans seems to be the primary sort of vector. And there's obviously, and there is a difference between the presentation of disease between healthy, immunocompetent, and immunocompromised hosts. And it's in the advent of HIV that we started seeing in the 80s this whole spectrum of disease of Bacillary Angiomatosis that wasn't really described before. With quintana, it's more lice, and it's very interesting that historically it was first described in World War I amongst soldiers in the trenches, and so it's hence labeled trench fever. And the introduction of sort of anti-lice measures has sort of largely solved that problem in World War I. But again, it does have a correlation with people, homeless people, and people with poor socioeconomic status. And just to take back a step, to mention that with henselae, while both henselae and quintana both cause BA, henselae implicated with both liver and splenic involvement in the form of ileosis, and quintana also doesn't cause liver and spleen involvement. There's a lot of writing on this slide, but this was a study where they basically went to a lot of detail to try and tease out the differences between these two, and just to maybe draw your eye to henselae on the right here, and the much higher percentage of cat ownership as well as cat scratching, much lower amongst the quintana group. And then the other thing, that the big difference being the socioeconomic characteristics of those that ended up getting quintana. So much more homeless, alcohol abusing, and poorer general hygiene. Although, I mean, not scientific, but I don't know many homeless people that keep cats successfully. But yeah, essentially just sort of highlighting that there are these characteristic differences between the two organisms, although they both present with the same skin manifestations. So going into the clinical side of things, so there are various typical cutaneous manifestations, and they present with three typical lesions, which are either pyogenic granuloma-like lesions seen on the bottom left, subcutaneous nodules, and then in people with darker skin pigment, they can present with hyperpigmented plaques. This is a patient from a slide that I got from Professor Mendelsohn, really nicely demonstrating these large subcutaneous nodular lesions, as well as this other more sort of pyogenic looking lesion on the face. In terms of the extracutaneous manifestations, lymphadenopathy is one. They can get nodular lesions both in the gastrointestinal and respiratory tract, and can present with GI bleeding or even compressive respiratory symptoms. And then in the liver, they get these vascular proliferative lesions, typically presenting more with a canalicular pattern, hepatomegaly. And in the spleen, they can present with splenomegaly and thrombocytopenia. Bone typically also presents with lytic lesions, and then there's a range of neurological presentations. And then, as we mentioned, we know well endocarditis comes in as well. This is just showing on the left the different the heterogeneous appearance between the liver and the spleen of a patient with pileosis spleenus. And then this on the splenectomy of this patient, this is just demonstrating these very vascular beds amongst the normal sort of white pulp of the spleen. And this is from that same study, which looked between the homeless people and the cat owners, just to highlight the point again that both lesions present equally with skin manifestations, lymphadenopathy much more common with Henselé, and liver and spleen involvement exclusively with Henselé, but bone and nodular lesions actually much more common with Quintana. The other thing that isn't on this, though, from what I had read as well, is that the neurological manifestations seem to be more common with Quintana than with Henselé. In terms of diagnosis, again, a very challenging diagnosis to make, and predominantly done histologically. And on the left, what we're seeing here is increased vascular proliferation, and on the right, again, just another example of a modified Morton-Starry stain. And although it is not uncommon that you don't get it on the Morton-Starry, and sometimes you only get it on electron microscopy or on prolonged culture or on genetic studies. In terms of treatment, very briefly, the uncomplicated disease, essentially only meaning cutaneous involvement, generally doxycycline or alternatively erythromycin or azithromycin for a duration of about 3 months. And for complicated or extracutaneous disease, it's suggested that you should add rifampicin and give a longer duration. In terms of recurrence, the recommendations are that if you treat it, even if the CD4 count is very low to start off, you should stop it after 3 months and see how they go and if they recur. And then if they recur, then to keep them on prolonged therapy until the CD4 count actually recovers. And there are documented cases of Jarisch-Herxheimer reactions in treatment. And then just to finish off, this is just another case found in the literature of a gentleman who was HIV and Hep C co-infected with a low CD4 count of 33 and was admitted with this very impressive lymph node lesion on the left anterior cervical chain, and had multiple investigations, including CT-guided biopsies. Well, they comment from the case report that he almost bled to death from the CT-guided biopsy, which is understandable considering the vascular nature of these lesions. And unfortunately, this gentleman eventually succumbed to compressive symptoms related to this lesion. And only in the post-mortem analysis on electron microscopy did they eventually finally make the diagnosis of Bartonella, and then they subsequently were managed to extract some material and do some genetic confirmation that this was a Bartonella quintana. And so in summary, we've just looked at a case of unmasking iris of Bacillary Angiomatosis, looked a bit at the spectrum of disease caused by Bartonella in overview, and some of the clinical differences between Henseleit and Quintana. A challenging diagnosis, it requires prolonged treatment, and recurrence needs to be watched for. And just to say thanks again to Safraz and Tari for doing all the work before me, which is always great. Thanks a lot.
Thanks very much indeed, Scott. That was beautifully presented and a lovely visual depiction of this problem. If you can stop sharing your screen, we can take comments. If you can, in the reactions, under the reactions button, you'll find a hand raising option. Interesting that last fatal case was Quintana, when you had said from that other small study that lymph nodes were only seen in patients with Henseleit. Maybe that relates more to cat scratch disease than to, or what are your thoughts about that?
So it's not exclusively seen. So the liver and splenic involvement seems to be exclusively with Henseleit, but lymph node involvement much more common with Henseleit, but is seen with Quintana.
So it's also interesting, I mean, in the case you showed of ours that, I mean, the follow-up picture actually after 11 days almost completely resolved, and that was with a macrolide with erythromycin at the time. But your doxycycline treatment in this patient, although better, I guess they're different lesions. They're not just the nodules. These are more broken out. I'm not sure, Gary or Graham or Sean, whether you've seen much BA iris. I think, Gary, the one I showed was we saw together, but yeah, Gary, over to you.
I mean, I was actually disappointed over the years not to see more BA. I've kind of had my radar out for a long time and actually struggled to find a handful of cases. So it seems to be very uncommon. I was going to ask a question about macrolides versus doxy. I'm sure it's a rare infection and there's no good data, but I would certainly not use erythro, but I think azithro might be a better option because it's got such great penetration. But I guess nobody's ever done head-to-head. Is doxy regarded as the standard of care by CDC, and where do they put macrolides?
Scott?
From what I can see, they don't favor one over the other. It's they recommend either as first-line therapy. I didn't see a justification for one over the other.
I mean, the reason we used erythromycin, I think, was the timing. You know, we didn't have azithromycin at the stage that we saw this guy. But as I say, it worked very well. Adrian, you've asked a question about the risk factors for culture-negative endocarditis with Bartonella, or do you mean risk factors for culture-negative endocarditis in general, Adrian?
No, I meant with Bartonella. Because, you know, I'd previously seen about one a year, which we only could identify with a PCR directly on a vegetation sent by the surgeon. And I could never really ascertain, and people ask what are the risk factors, and I'm not sure. I didn't know if Scott came across anything in the literature. I'm not sure there is anything. I mean, the association with HIV, and so that's completely different. There is some literature on it, but not. It's an important cause of culture-negative endocarditis because it's not grown, and therefore we think we're dealing with a HACEC organism. But if you do not do a pan-bacterial PCR on a valve that is a vegetation that's sent in, you never pick it up. So previously where I worked, we had a protocol where we would do a pan-bacterial PCR, and that's how we picked them up. which we otherwise wouldn't have had. And the outcome in these patients it's really poor because they don't get the right antibiotic.
Scott, any thoughts?
So, I mean, my understanding from what I've read, just in looking at overarching at Bartonella, is that the sort of, the angiomatosis is really something we're seeing with advanced HIV and advanced immunocompromise, whereas it's the sort of more chronic bacteremia that would, and someone with a predisposition, so someone with an underlying valvopathy of some sort, would be the ones more likely to develop endocarditis. But I defer to more experienced and knowledgeable people.
Sure. I mean, it's per se not a very virulent bug compared to the other stuff. That's why I'm asking. I mean, in HIV, we'd understand why it would present such way, but not in an otherwise healthy person. Anyway.
Yeah, but I mean, the risk factors are probably for Bartonella culture negative endocarditis is owning a cat or a louse. So if you have either of those, Adrian, I would be wary. Goa in the chat has quite rightly said that that at GSH, the study that was done on explanted valves at 16 SPCR showed Bartonella as the leading cause, and it was Bartonella quintana in our setting, and hence the importance of doxycycline in the culture negative group. Gary said, from no pet cats to pet lice, indeed. Okay. Unless there are other points about this, I mean, I think it's a really nice example of why, particularly for nodular lesions in HIV, in advanced HIV, biopsy and asking for specifically for Warthin stari, modified Warthin stari stain, is important. And but bacillary angiomatosis are usually violaceous nodules, or they're reddened, and so they do very much have a differential diagnosis with KS. The other lists of differentials you used, really, I mean, I would put KS and BA at the top, and then the others really come late down. Sporotrichosis, we've seen, subcutaneous nodules, they often have lymphatic distribution, as and we saw 1 or 2 cases of that as well, but they're not generally violaceous, and they're subcutaneous nodules, very much subcutaneous, and don't affect the skin so much. So, Scott, thank you very much indeed. Really appreciate that. A lovely presentation.